Hello, everybody. We are talking about the kidney and the urinary system. So these are our objectives. So let's start with the kidney, and we're going to start with the nephron. So the nephron is basically a long tube that things are secreted or absorbed through the nephron, and then the end product goes out of the body and basically is urine, where waste are removed from the body. So a few things you need to know. First of all, this is the Bowman's capsule, and it surrounds the glomerulus. Glomerulus is blood vessels, like capillary blood vessels that kind of come into the Bowman capsule, and certain substances are released and water is released. So substances that are less than 40 kilo decimeters is pass through the glomerulonephron. You don't need to know that number. All you need to know that they have to be a certain size to pass through. So larger things like proteins and other fats, those kind of things blood cells do not go into the bone capsule. So just usually electrolytes, waste products, and water are put into the tubule. So those are released from the glomerulus into the Bowman capsule, and then they go through the proximal convoluted tubule. So proximal means it's closest. So closest to the Bowman capsule is the proximal convoluted tubule. And in this, secretions of hydrogen ion and nitrates, creatinine, and drug metabolites are secreted into the tubule to get rid of out of the body. Also, in the convoluted tubule, glucose, any amino acids, most salts by diffusion or active transport, and most of the water by osmosis is reabsorbed back into the body. So you do need to know where things are excreted or reabsorbed. So again, glucose, amino acids, salts, and these are usually by diffusion or active transport, and most of the water by osmosis. So diffusion, remember, you think back in the beginning of the semester, diffusion is the movement of particles, whereas osmosis is the movement of water. Then it goes to more of a narrow area here, and they call it the nephron loop, but this is the loop of Henle. And this is where some water is again reabsorbed back into the body by osmosis. So that means that the oncotic pressure over here is high, so the water will move towards that oncotic pressure or has a higher concentration of solutes. Now, after the loop of Henle, it goes through the distal convoluted tubule. So you'll see that over here. And some salts are reabsorbed by active transport. It depends on what your body needs. So if it needs to reabsorb some salts, it will in this distal convoluted tubule. I'm going to move myself here. But it depends on what's in the body again, what we need and what we don't need. Secretion of the hydrogen ion, potassium, sodium, and chloride can also be moved into the tubule to be excreted if the levels are off. So you see all these things that are done. And then it comes down here, and then this is the collecting duct. The collecting duct then will connect to ureters that then go down to the bladder and are excreted. You might have some water reabsorbed here depending on the osmolarity again and whether the body needs the water. So metabolic waste like urea, creatinine, uric acid, excess water, and salts are then removed from the body. So to know if what the nephron function is like, the 99% of the glomerular filtrate is reabsorbed. So most of what goes into the nephron is pulled back out if the body needs it. So most of it's going to be pulled back out. Fluid begins in that, again, the glomerulus or the glomeruli right in here in the Bowman capsule. It has electrolytes. It has organic molecules. It is permeable to water, but not large colloids like proteins. So large things cannot make it through. Like again, blood cells, like red blood cells, white blood cells, cannot make it through. The net filtration pressure depends on the blood pressure, how much fluid is coming in through the vessels that then goes into the Bowman capsule. So if you have a low blood pressure, it's a smaller amount. The oncotic pressure, the oncotic pressure that changes how much water is moved is important, and also the charge of the molecules too. And the pH of the blood also matters because that's when the hydrogen ion is either absorbed or removed. Excuse me. Goodness sakes. Sorry about that. The proximal tubule, like I said, reabsorbs sodium, glucose, potassium, amino acids, bicarb, phosphates, urea, and water. Secretion of the hydrogen ion is here. So this again depends on the pH of the blood, how much extra hydrogen ion you have floating around in your blood, and foreign substances like drugs. So if a drug is excreted through the kidney, it is done in the proximal tubule. That is where the drug is removed. Some reabsorption is done by active transport. Remember, you need energy for active transport, such as glucose. Glucose is removed by active transport out of the urine. If the active transport, you only have so many of those spots on the membrane of the cells for that active transport. Once those are full, it can't do that anymore. It can't reabsorb because of active transport, so some things will be lost. So if you think about glucose, if you have a high blood sugar, then you're going to spill that glucose in the urine because the active transport is full of other glucose. So that's one sign of diabetes is glucose in the urine. And because that changes the osmotic pressure in that fluid going through the nephron, that glucose will pull water back into the nephron and you will excrete it out in your urine. And because of that water shift into the nephron, then your body will need more water, so you become thirsty. So again, when it's become saturated, then loss will be done into the urine. And the fluid is isotonic, so it's at a nice steady pH. So it keeps the same pH as, or electrical charge or pH as the blood. So it will not be more acidic or basic or anything like that. Then the next part, we talked about the loop of Henle. This is concentration of the urine occurs. You have a countercurrent mechanism. So the loop of Henle goes right by itself. So that way it can pull out in different parts of the urine, and you have a kind of what you would call a bigger surface area. It has a descending loop, and that water reabsorbs and sodium diffuses. And then the ascending loop, sodium is then reabsorbed by active transport. So during this process, sodium is really the key player here. And of course, water is done by osmosis. So remember, we talked about sodium. Whenever sodium moves, water kind of goes with it. Also, urea is secreted in this segment. And the fluid can be isotonic, hypertonic, or hypotonic, depending on what's going on in the body. The distal tubule, then you reabsorb sodium if you need to, water, In this case, if your reabsorption of water, usually the ADH or antidiuretic hormone is required for that, and also bicarb, and that depends on the pH of the blood. Secretion of potassium, urea, hydrogen ion, nitrites, some drugs are secreted here. So some, remember, are in that proximal, some are in the distal. And the fluid is hypotonic. So there's not a lot of electrolytes left in that distal tubule because they've been reabsorbed. And then in the collecting duct, which is then going to go out to the ureters, you reabsorb water again. It depends on your ADH levels, reabsorb secretion or secrete the sodium, potassium, hydrogen ion, or nitrites. It just depends on what the body needs. Urea is reabsorbed in the medulla, and fluid is the final concentration of your urine. All right, so the glomerular filtration rate is something that you'll hear about as a nurse practitioner. And this tells you whether you can give certain medications or certain treatments, or how bad the kidney damage is. So the glomerular filtration rate is the rate that the fluid in the glomeruli filters into the Bowman capsule. It will increase with low levels of plasma proteins, decreases that low level of proteins, decreases the osmotic pressure. So if you don't have many proteins in the bloodstream, then it decreases the osmotic pressure of the glomerular blood. So you have more water than solutes. So more water is going to be dumped into the nephron. You might have this with malnutrition because you don't have the proteins from malnutrition that will hold the water into the bloodstream. Liver disease as well. Substances that would attach to a protein that are not, those not attached would be filtered out. So what you have is there's a lot of substances that go to a carrier protein and they bind with that protein, and that protein then carries it throughout the body wherever it's needed. If you have extra of that substance, that free substance will then be secreted out in the nephron. What does happen with that is it pulls water with it. So when you have that part that is kind of free floating and it's secreted out the kidney, then the plasma proteins will release it to keep an equilibrium in the bloodstream. So it will release it. And so that again will be going out into the nephron and then be released throughout in the urine. So it tries to keep an equilibrium of the free substance. So when I talk about substance, I want to think of a lot of things will attach to albumin in a lot of medications will attach to albumin, or a lot of waste products will be attached to albumin, and then you'll have that steady state. So, if we're looking at, I can think of bilirubin right offhand. If we look at bilirubin, it attaches to a plasma protein, and our liver filters that out, but it has to be conjugated or attached to a protein to be removed. So whatever's free or unconjugated or indirect is a substance that we don't want, and that will change your oncotic pressure. So as that substance is removed through the nephron because it's small versus a protein that cannot move through the nephron, that is excreted, well, then the protein's going to release it to keep an equilibrium in the blood, and that is going to also be removed out. And as those things are removed out, water follows it. I hope that's clear. Now the filtration rate will decrease, so this is decreasing the amount filtered out of the bloodstream or the glomeruli, and that decreases with an obstruction to the outflow of urine. So if you have a stricture or stones or something where the urine cannot be removed, then that will cause damage in the nephron and it doesn't do a very good job of filtration, and you have scar tissue or fibrotic tissue forming in the nephron, and that's kidney damage that's not going to be fixed and you can't filter through it. Or you have excess loss of protein-free fluids, and that increases glomerular oncotic pressure. So with vomiting, diarrhea, use of diuretics, so you're losing a lot of what we call free fluid. You're vomiting, you're throwing up fluid. Diarrhea, it's coming out in the stool. Diuretics, your excessive urination. So because of that excess removal of water, your oncotic pressure in your bloodstream is high. So then you're going to kind of reabsorb that water to get the osmotic pressure down. So not as much water is coming across the glomeruli into the Bowman capsule. Another way to lose fluid would be excessive sweating. Now, the kidney does release some hormones as well. It releases antidiuretic hormone. We've talked about that. This determines your final concentration of urine. This is released from your posterior pituitary, and it is judged based on your blood pressure, the oncotic pressure in your blood. So it's basically your brain is sending us signals saying, we need to release more water or we need to retain more water. So the antidiuretic hormone is retaining water. Natriuretic peptides, there's several. There's the urodilan, I want to say dilan, but that's not right. Urodilatin, and that's produced in the kidney, and that regulates your water and sodium balance. The NAP or atrial natriuretic peptide and the BNP, the brain natriuretic peptide, these are released by the heart due to stretching. So as the heart muscle stretches, it releases these two peptides that then will promote diuresis, getting rid of that extra fluid. So the heart is saying, I'm stretched, I have too much fluid coming in. It releases those, and then that is telling the kidney, well, it's telling the vessels to dilate and to get more fluid down to the kidney. And in this dilation of the vessels, it causes your blood pressure to drop. So you usually see this in heart failure because the heart is stretched over its size, and then they lose that. Vitamin D, we have D3, which is your inactive form. Your body will convert it to the active form. The inactive form comes from the sun or it comes from food. Most of the foods are fortified with vitamin D. So one of the most common ones that's fortified with vitamin D is milk. You see vitamin D in cereals too. And this is kind of an older school thing, just because back in the day when I was young, everyone ate cereal for breakfast or whatever. And so they got vitamin D that way. So you always had milk. So, you just have to remember that with dietary, what's a good source of vitamin D to have naturally, or you can take supplements of vitamin D as well. Remember, vitamin D is fat soluble though, so you don't want to overdose on it. You don't want too much because it will be stored in your fat cells. Calcitriol is the active form of vitamin D, and it is converted to the active form by the liver and kidneys, and this is stimulated by the parathyroid hormone. And this causes absorption of calcium and phosphorus or phosphates. So this will regulate those levels. And remember, we talked about this with the bones. If your calcium is high, your phosphorus is low, and vice versa. So it wants to keep it in a steady state, so we're not leaching out the bone for these electrolytes and minerals. It also releases erythropoietin. This stimulates the bone marrow to produce red blood cells. So if you don't release that, the bone marrow won't produce them, and then you become anemic. So some structural issues, let me move myself down here. Some structural issues you have with the urinary system. This is kind of an old picture, but I like it because it shows a lot of different problems. Um, it's caused by obstruction in the kidneys or urethra. Just making sure. Yes. Or, oops, sorry. Oh, no, no. I can't go back, can I? Hold on. Hold with me. There we go. So you can see there's lots of different causes of obstruction. It can be the kidney itself. So you can have polycystic kidneys where you have all these cysts here. The fluid is not being taken to the pelvis that then drains down. The cysts, they just get bigger and bigger. And it's basically a non-functioning kidney. You'll see the pelvis of the kidney is dilated here, where you can't even see the pelvis over here. It's within the kidney, but here it's dilated so much it's sitting outside of the kidney. So that is not draining properly. Um, or you have hydronephrosis. Hydronephrosis is where the fluid has not drained from the pelvis. You could have dysplasia or agenesis of the ureter, so that is very tiny and it doesn't drain properly. It's very small. You could have problem with the uretopelvic valve. This is the valve that comes off the kidney, that drains the urine down to the bladder. It is a one-way valve, so you want to make so it's basically pushing the urine down towards the bladder. Um, we're not always sitting upright where you have gravity to help you. So you have this valve so it doesn't come back into the kidneys. But if you have something wrong with that valve, then it could flux back into the kidneys. Could have a stricture, just a narrowing area of the ureters, a fibrous band that's wrapped around the ureters, stenosis. So stenosis is tough. It's not elastic, so it doesn't expand as the fluid comes out. So it causes a narrowing. You could have a urethral orifice, or I'm sorry, urethral orifice. You do have a urethral orifice. That's where the ureters are draining into the bladder. There's another valve here. This is the posterior vesicouretal, vesicouretal valve, and that allows the urine to stay in the bladder and not go back to the kidney. And then once you're in the bladder, you're into the urethra after that, and you could have enlargement of the prostate if you have a prostate. You could have a urethral sphincter sitting right down here, so you could have something wrong with that valve, or you could have urethral stenosis. So there's lots of different ways that the urine can be blocked. Some other things, carcinoma of the renal pelvis. So you could have a tumor in here. Blood clot in the ureters also will block urine. Um, Intrinsic factors like pregnancy, sometimes the baby is sitting right on top of one of your ureters and it's not draining down and it's causing hydronephrosis. It's almost quite common in women who are pregnant that, that sometimes happens where you have that blockage and it's just once you have the baby, it gets better. The problem is it can cause kidney damage. It can also cause kidney stones to form if it's not draining properly, so they are at risk for that. Carcinoma of the cervix, which can spread then endometriosis, which is endometrial tissue that could be on any of these surfaces that causes scar tissue to form. Prostate hypertrophy, like I talked about, where the prostate is enlarged. The prostate sits here at the bottom of the bladder. Or carcinoma of the bladder, where you have a large tumor in the bladder and it's blocking the drainage of urine. So we talk about some different tests. Just going to go over those. You probably have heard of all these before as a nurse. You learned about these in nursing school, but we're going to just refresh. So IVP is intravenous pyelogram. This is where you start an IV, you give the dye through the IV, then it comes through the vessels and it goes into the kidneys, and this is the IVP here. And so then you see here that the dye is filtered out through the kidneys and goes into the urine, and then it drains in the bladder. So it's kind of a top down kind of thing. So you're watching the dye go from the kidneys down to the bladder. So you're looking for some kind of damage in the kidneys. So here you would see over here, it's not really draining. You see like a little line of dye. As white as the dye. Here's the bladder. And it's not draining well from this right side over here. So it's not draining into the bladder. VCUG is a voiding cystic urethrogram. So dye is placed in the bladder and um, the bladder is distended until you can't stand it anymore. And then they urinate. And as they urinate, the contraction of the bladder is pushed downward to evacuate the urine. And on reflux, you'll see it go back up into kidneys. So this is a voiding cystic urethrogram here. You can see the bladder is very large. They actually can get quite big. I had one long time ago, and I have a nurse's bladder. We can hold our urine forever because, sometimes we don't have time to go to the bathroom. And so I tell you, my bladder was humongous, and they were like, "Do you feel like you have to go to the bathroom?" I'm like, no, not really, because used to having a very, very full bladder. Not a good, healthy thing to do, though. You see in here, you say they look the same. The only thing is this one, the bladder is not totally full. It's kind of flattened out. So usually that's a line of the fluid line there, or it could be, but it would be showing that the bladder is emptying. This is from bottom up. So we're looking at the bladder and this dye going back up into the kidneys. A cystoscopy is where they put a camera in, insert it in the urethra, and they go up as far as they can go. And that's what this is a picture. I'm guessing this is inside the bladder, just because you see these rugae here. The bladder on the inside is has a lot of rugae, and so that it can stretch quite a bit to hold quite a bit of urine before you're uncomfortable. Kidney stones. So kidney stones are horrible. I've never had them, but I hear they're like the most painful thing ever. And you see these pictures and you see these jagged edges and you're like, well, no wonder it hurts so bad, right? So if there are in the kidney, that's nephrolithiasis. If it's in the bladder, that's urolithiasis. They can consist of calcium oxalate, calcium phosphate, struvite, uric acid, or cysteine. My aunt had these, and she was always afraid to take any calcium supplements because she didn't want to get them again. And so usually this has to do with you just tend to be prone to them, or you have a diet that doesn't have a lot of free water to flush out the kidney. So some of these crystals start to form inside of the kidney. A staghorn calculi are very large and they fill the renal pelvis, and you're not going to pass those. There's just no way. So those have to, excuse me, those have to be broken up before you can excrete them, and then they're usually removed that way. Non-staghorn calci have variable shapes, and they can be in the renal pelvis, or the ureters, or the bladder, or the urethra. They're all quite painful. All right, incontinence. So what is incontinence? That's basically a loss of urine when you don't want a loss of urine. So there's different types. There's your urge incontinence, and this is loss of urine when you have a strong desire to go to the bathroom. So if you feel like you need to go to the bathroom, maybe you're heading towards the bathroom and you see the toilet and suddenly like, oh, I can't hold it any longer, that would be urge incontinence. Stress incontinence is an involuntary loss when you do something that causes pressure in your abdomen. So, coughing, sneezing, laughing, or other physical activity, you are pushing pressure onto the bladder and it releases the urine. These are typically due to poor pelvic floor strength. So we're going to talk about that in a second. Overflow incontinence means involuntary loss of the urine from overdistended bladder. It's typically associated with some kind of neurological lesion, or polyneuropathies or urethral obstruction. So typically that is when you can't empty your bladder the way you should, it becomes overdistended and then it just kind of leaks out. Mixed incontinence, usually you have urge and stress together. Functional incontinence means is involuntary loss of urine, and that's due to some kind of brain lesion, like dementia or immobility. Neurogenic bladder is caused by a neurological disorder, and that involves the storage of urine and how you void. If it's an upper motor neuron lesion, that is dyssynergia, and that is a loss of coordination of the neuromuscular contraction, an overreactive or hyperreflexive bladder. So you are squeezing your bladder or whatever, you can't control it, and you can't hold much in your bladder. You just are releasing the urine frequently. Lower motor neuron lesions, this is underactive hypotonic or atonic bladder function. And this you have with the loss of bladder sensation. So you can't feel, so maybe you've had a spinal cord injury and you can't feel your bladder being full, and then it will just empty. So these pictures just kind of help you with this. You know, this is normal right here. You know, this is where you innovate for the different areas of your bladder into your spine. For a brain injury here, so supraspinal or in the brain tissue, what happens is you usually have bladder dysfunction observed if you have sacral, radicular, or peripheral lesions. Oh, I'm sorry, that's for the bottom one. So this is brain injury here. So what happens is you have frequency that the urge to breathe, you urge to urinate, and you have sphincter synergy. So you have hyperreflexia. So you have to feel like you have to go to the bathroom all the time, and you're not holding as much urine, so the bladder is kind of flat. If you have a lesion above the conus medullaris in your spinal cord, then oh my gosh, keep hitting the wrong thing. I'm sorry. Let me move myself again so you can see. Maybe I won't. There we go. Then the bladder becomes very hyperreflexive, and you have not a good signal between a full bladder and the sphincter control. So you would lose urine that way. Bladder dysfunction in the radicular or peripheral lesions. So this is very low. You see these are the lumbar nerves and the sacral nerves. So a lesion is way down here. These people usually can walk and do other things, but their bladder just gets really distended because they don't feel the fullness of their bladder. So they have incontinence because their bladder's too full, and then it will drain out. So obstructions of urine flow, you can have a urethral stricture. It can be a prostate enlargement in men. Pelvic organ prolapse. So for these, you can have a cystocele, which we're going to go over these in a second, but this picture is a prolapse of the bladder in the scrotum. So you see the dye here. So this is a VCUG because you don't see it coming down from the kidneys, which is normal. So you have your bladder here full of dye, but you see a pocket of dye here. And this is because there is a prolapse of the bladder coming down. Typically, this is coming down maybe through the inguinal canal. So the inguinal canal is where the testes come down when you're a baby, and then they seal off, but it's a weakened area. So you can get hernias of the intestine, bladder, anything like that coming down through the inguinal canal. Also, partial obstruction of the bladder, outlet, or urethra. So let's talk about those organ prolapses. So you can have, and this is normal. This is a normal female. You don't recognize it. Second. My cat is bothering me. Um, this is normal. It's a cystocele if the bladder is prolapsing down into the vagina here. So you see the urethra here, and then you see the bladder coming down here. It's blocking the urethra because of this pressure from the side. And it's also prolapsing into the vaginal area here. So you can actually come down out the vagina right here. You can have a rectocele, which is where the rectum is prolapsing down. It is also putting pressure on the urethra and the vagina here, and stool gets stuck in here. This happens with chronic constipation. People with that, where that sigmoid colon becomes distended. Or you can actually have uterine prolapse, which will put pressure on the bladder as well, and also the urethra. All right, urinary tract infections. Um, Urinary tract infections obviously are caused by bacteria for the most part. I don't know if I've ever seen a viral urinary tract infection. I don't know, maybe, but usually it's bacterial. And you can have acute cystitis, which is the most common. That's inflammation of the bladder. Typically, it's staph because staph lives everywhere on our body. It's hard to get rid of staph. So staph kind of likes darkness. It always seems like it's always in the creases of your body. So, because it lives on the surface of the skin and it likes warmth. So, usually that's why you get like staph infections and creases. So, it's the same thing here. That might be creeping up the urethra or E. coli. I'm sorry, I thought I was going to sneeze. Anyways, E. coli, which is coming out of the stool. Obviously, you're not clean down there. And so, the poop chute and the pee hole very close together. So that's not the medical terms, but you know what I'm talking about. So they're very close together, so it can actually inflame or cause acute cystitis, very painful. Interstitial cystitis is painful bladder syndrome, but it's not infectious. And it can last more than 6 weeks. So that obviously is followed up with a urologist. Or you can have acute pyelonephritis that is an infection in the kidney, ureter, um, somewhere up high in the urinary tract. So glomerular disorders, remember the glomerulus is that bunch of blood vessels that sits right in the Bowman capsule. Acute glomerulonephritis is inflammation of the glomerulus due to primary glomerular injury. So acute means just that it just happens. It's not like a gradual thing, it happens. Typically, it's due to immunological response. It's an overreactive inflammatory response, ischemia, free radicals, drugs can cause it, toxins, vascular disorders, infections. If you're going to think about infections, it can happen after a strep infection. So it's not infectious. We're not treating it with a antibiotic because it's post-infection. So typically, if you had strep throat or something like that, it can cause acute glomerulonephritis. So we don't treat it with antibiotic. Obviously, if you have another infection on top of it, they would treat you with an antibiotic, but it's the post-strep. It's the damage that the strep infection has caused to the glomerulus. Secondary glomerular injury, this can be caused by certain systemic diseases like diabetes, which is one of the number one reasons of damage to the kidneys is diabetes. Hypertension is another one. Systemic lupus, congestive heart failure, or HIV can cause an injury to the glomerulus. And this, once that's damaged, it's really hard for it to heal. So usually it becomes scarred, and that leads to chronic kidney disease, where eventually the kidney will fail. So you'll be in the end stages of renal failure. So you have to catch this early and prevent any further injury. Or chronic glomerulonephritis, and that again can lead to the chronic kidney disease. Nephrotic syndrome. What happens with nephrotic syndrome is that the glomerular permeability increases. So protein is lost into the urine. So typically, proteins are too big to cross that barrier between the glomerulus and the Bowman's capsule. In nephrotic syndrome, there's something damaged to the Bowman's capsule that these proteins can now leak in to the tubular or the nephron. As that protein moves, the oncotic pressure changes. So you're losing protein out into the urine. So remember, the proteins kind of maintain that oncotic pressure. So if you're moving all those proteins, what comes with it? Not much, because what happens is you have too much water in the blood vessels, and that leaches out of the blood vessels and causes edema. So it's because you don't have enough protein in the bloodstream that now you're leaking out fluid throughout the body. You have hyperalbuminemia, which is low albumin levels. That's that big protein that carries a lot of different things. And that's lost into the urine as well. So again, that causes edema. Now that extra fluid leaks out into this interstitial tissues. You have edema also for sodium and water retention. You have increased aldosterone and antidiuretic hormone secretion. And remember, the heart becomes the heart is releasing that ANP, but your body is unresponsive to that. So because you don't have the serum albumin, you have increased lipoproteins are produced. If you don't have the albumin, then the liver is going to make those lipoproteins. And those lipoproteins are not healthy. They will block your vessels. They will cause damage to glomerulus because they can't filter them through. It will increase your cholesterol levels, your phospholipids, and your triglycerides. So it can do some serious damage to your heart. If so, you don't have the albumin, which is the happy protein, you start to make these lipoproteins to maintain the osmotic pressure in your blood vessels. So the liver is trying to help you out by maintaining that oncotic pressure. But what happens is it just raises all of those fats in your body, and then you have blockages in your arteries. Also, you have decreased vitamin D. Globulin that carries the form of vitamin D is lost in the urine. So vitamin D, again, has to bind to that protein to get to where it needs to go. That active form, the vitamin D with the protein, is now leaked into the tubule and gone. And also hypothyroidism, because thyroid binding globulin in the thyroid hormone is binding to another protein that is lost in the urine. So you're losing all these important proteins that carry things in your body. Acute injury, this is a very rapid thing that happens. It could be reversible, but you'll have damage, renal insufficiency. So you have a decline in the renal function of 25% of normal. You could go into acute renal failure, and this could require renal replacement therapy. So like a dialysis. Usually it's short term though, because tends to be reversible. You'd have uremia. So you have elevated BUN and creatinine in the blood, and you also have elevated urea and creatinine, and that's azotemia. So chronic kidney disease, A and B, top two problems for chronic kidney disease, what causes it? And it's usually hypertension, which causes damage to the kidney, and diabetes mellitus, because that's too much glucose and it starts to bind to tissues and it causes decreased filtration. Lupus can cause it, acute injury, if it's not taken care of, can lead to this. Chronic glomerulonephritis, chronic pyelonephritis, if you have a lot of inflammation, damage to the kidney, obstructive uropathies, and vascular disorders. So what are the effects of chronic kidney disease? So remember, the kidney does a lot of stuff. So if you have chronic kidney disease, you have a lot of issues. And obviously, chronic kidney disease leads to uremia, so urea building up in the bloodstream. So you have vitamin D and calcium deficiency because the kidney can't make the calcitriol that will help with calcium reabsorption and all of that. So, and also you're losing vitamin D with that extra protein there being lost in the tubule. So you're not making the vitamin D, so you can't regulate your calcium and phosphorus. So your bones become very brittle. You have bone pain and fractures. Pulmonary edema, this is due to that systemic edema because of the loss of proteins, and that can lead to metabolic acidosis. Left heart hypertrophy, this is due to high volume because you're retaining all that fluid because it's not going out in the kidneys. You have volume overload, and then you also have that hyperlipidemia that leads to atherosclerosis. So you can't get the blood out of the heart because you have all this resistance. Encephalopathy, and that's due to accumulation of the uremic toxins in the brain. If this happens in children, it can cause growth restriction because you have elevated parathyroid hormone and decreased thyroid hormone. Anemia because you don't make the erythropoietin. GI issues like nausea and vomiting, mouth ulcers, GI bleeding, pancreatitis, and this is due to retentions of the metabolic acids and waste. Abnormal pigmentation and pruritus or itchy, and that's due to retention of the urochromes. So your skin will have a yellow color. You have high calcium levels and neuropathy, and that can cause pruritus or that itchiness. Increased risk of infection, so you can have suppression of cell-mediated immunity. And then it can also affect your reproductive system, so dysfunction of the ovaries and testes. I'm just going to tell you though, if you have chronic kidney disease, it doesn't mean that you can't get pregnant. I mean, you might still be able to get pregnant. So for children, urinary tract disorders, pretty similar to adults, but they do have some genetic structural problems like hypospadias. Hypospadias is a urethral opening at the bottom of the penis. So if you look here, there's different types of hypospadias. It could just be at the very base of the glands. It could be along the shaft of the penis. It could be all the way down to the scrotum. Epispadias means that the urethral opening is on top of the penis. So like in this picture, hypospadias is the most common. Typically, a hypospadias goes along with a chordee. A chordee is where you have right along the base of the penis, along the shaft here, it is increased tissue and it's very fibrous tissue and it causes the penis to curve, and that's a chordee. Extrophy of the bladder is where you are born with the bladder on the outside of your body. I've only seen that once back in the day because we didn't people didn't get ultrasounds like they do today. So we saw a lot of things, but the exstrophy of the bladder that I saw, the bladder wasn't fully formed. So it almost looked like a shell. It was like half and had all these rugae. And the urine, you could see the ureters, they were just draining out everywhere. And yeah, so yeah, ended up needing surgery, but the baby was really small, so they usually wait, and they said that they just put like a sterile dressing on it and then just change the dressing like you would change a diaper, because it just gets urine there. So yeah, it was interesting. Polycystic kidneys are cysts in the kidneys, and this leads to nephrotic dysfunction, and basically those are non-functioning kidneys. The other things, glomerulonephritis, nephrotic syndrome, we've already talked about those. It's basically the same as for an adult. And vesicuratal reflux means where you have retrograde flow of urine back into the kidneys, or basically a flux of urine from the bladder up. And this is usually congenital. And like I said, now they do so many ultrasounds of moms, so they see it early on. So when the baby is first born, if we know about it a couple days later, we'll do an ultrasound and see if there is hydronephrosis or enlargement of the renal pelvi. Well, that's all I have. If you have any questions, please let me know. Have a good day.